All right. Hello and welcome to Immaculate Dissection's Ask Us Anything webinar. I am Dr. Anna Folckomer, one of your co-hosts. I am joined with another one of our co-hosts, Danny Quirk, and a couple of our ID team teaching team members. Dr. Dooley is unable to make the meeting this evening, but of course, as always, the ID family sends her our love. So thank you so much for everyone who is here. We have been doing these every single week. I believe this is our fifth one. So happy fifth webinar anniversary, friends. These have been a lot of fun. We just open them up to our ID community for people to pop in, ask questions. We've had some questions submitted to us on social media that we'll cover tonight. And yeah, you know, I think people seem to be enjoying these. And so this is an opportunity for us to kind of suck you in and help you, you know, sort of see things through this lens that we try to sort of tackle some of our rehabilitative problem solving strategies with. So we're super excited to have you here. Like I said, my name is Dr. Anna Folckomer. I am an acupuncturist, an herbalist, and an anatomist, and one of your co-hosts and co-founders of this. And also I have with me another co-founder, Danny Quirk. Danny, do you want to introduce yourself?
Yeah, of course. Hey, everybody. I'm Danny. I'm one of the co-founders of Immaculate Dissection along with Anna and Kathy. And I'm the artist for Immaculate Dissection. So anybody who's familiar with the seminars, you know, I'll do the body paint and then the artwork for the manuals, as well as visual aids and visual representations to help visualize some of the complex concepts that are taught at the seminars.
Awesome. And he does an amazing job and may even give you a sneak peek at some of his visual support that he contributes to our course tonight. So hold on. I am also joined by some of our favorite teaching team members who have also helped us out with a couple of these webinars. And we love your input so much. So Team Toronto, who do we have? We've got Monica and Lisa. So whichever one wants to go first, jump right in there.
I'll start. I'm Lisa. I am a physiotherapist in Toronto. I'm also an anatomist. And yeah, these have been a lot of fun. It's just fun to kind of talk through a lot of the anatomy that's involved in treatment and how we approach things from that anatomical lens. So I hope you guys enjoy.
Awesome. And Dr. Monica Chadha.
Hi, I'm Dr. Monica Chadha. I'm from Toronto as well, and I'm a chiropractor, and so excited to be here. These are a lot of fun, so keep the questions coming, guys.
Yes, and who's just popped in, but none other than Dr. Kris Kirby, representing the Midwest over there. Hello, Dr. Kirby. You want to introduce yourself?
Sure, Anna. I'm Dr. Kris Kirby. I'm just a chiropractor from Southern Missouri. And not a very good internet connection.
Just hang in there. If you need to come in and out, that's totally fine. We just appreciate you being here. And we've definitely got some questions that, you know, we would love your input on, just because you are an absolute wealth of knowledge for this family. So Immaculate Dissection is super excited to, you know, have these on a weekly basis and have you guys join us. We do encourage you, if you have questions that you did not get a chance to submit yet, feel free to scroll down to the bottom of your Zoom screen. And right on the next door neighbor to the button that says share screen is your chat box. So feel free to post in there if you would like, and we will get to those after we get to the couple of questions that were submitted earlier. And we'll tell you also about a couple of really awesome things that we've got going on right now. And at the end of the seminar, we will offer a $50 off coupon to anybody who can answer a couple of anatomy questions for us. So without further ado, let's get started with our first question that was submitted via the Instagram land. And the question is, how can you heal diastasis recti without surgery? Which is a really interesting question. We were just joking actually before the seminar or the webinar started that you could practically start a diastasis clinic, because it is such a problem for a lot of people, not just postpartum. We see this with a lot of different clienteles. This can, happen very frequently. We see in like 2 out of 3 pregnancies. So it is something that we do actually address pretty substantially in our ID1 core concepts class. So in ID1 core concepts, we do cover the anatomy, and the brilliant Danny Quirk has a wonderful visual, not only that you get to take home with you after the course, that just allows an actual tangible rectus sheath in your hands. That is amazing. It's always so fascinating. We've worked with healthcare professionals for 6 years now in terms of continuing education. And this conversation and this topic of discussion just blows people's minds, because we understand that it is really under-discussed in a lot of anatomy classes. I know that my anatomy training did not go into the depth that I would have liked to about the rectus sheets and, some of the clinical pearls that are associated with it. And even when I'm in the lab and I'm super excited and I'm showing it to a lot of my students, some of them are kind of like, wow, yeah, but what do we need to know for the test? So we are here to reinvigorate the idea of the rectus sheets, because man, that is a treasure in and of itself in terms of how we can apply that clinically. So Danny has a beautiful visual, and he may even give you a sneak peek of that this evening. But we also do a bloodless dissection of this, which is pretty freaking cool. So Danny has dissected my rectus sheaths I don't know how many times at this point. It never stops being cool, guys. I just have to throw that out there. So what is the deal with these rectus sheaths? The rectus sheaths are made up of the tendinous aponeurosis, and aponeurosis is a broad, flat tendon. And so when you look at things like transversus abdominis, internal abdominal oblique, external abdominal oblique, these things all share an attachment via that linea alba that runs straight up the midline of your torso. And this is the first scar that we have, because in utero, everything sort of forms on the outside of you, migrates in, and you zip up the front. So this is a pretty significant marking on our bodies. And as the abdominal muscles need to be able to attach here, they aren't just a muscular flap that wrap all the way to the front and then sort of join up in the center. They become tendinous and they turn into sheaths, and they are actually bilaminate sheaths. Now, external abdominal oblique stays in one piece, as does transversus abdominis. But internal abdominal oblique does this pretty sneaky thing where it splits into an anterior and a posterior sheath. And that is really, really important, because it's one of the reasons why internal abdominal oblique can act as an intrinsic core support builder, but also as an extrinsic muscle. It's sort of a liaison to help you to communicate with the outside world. So it knows how to sort of speak both languages of intrinsics and extrinsics. So in ID core concepts, one of the things that we do, one of our most important assessments, is this supine 90-90, where we split the abdomen up into a couple of different places. And the highest priority for us is the area between the costal margin and then something called your arcuate line. And the arcuate line is a kind of a favorite topic for the ID team, just because we appreciate so much what it does in the body, but we also appreciate how many different techniques acknowledge this area of the body. It's about a third of the way down between your umbilicus and your pubis. And this arcuate line, it is nodded to and acknowledged by so many different techniques throughout history, really. Meditation. I know Kathy shares a beautiful story about how she was connected to her husband this way because they both had such a strong connection to this area. I know in Chinese medicine, which is something that I've had the privilege to study, this is a big point for qi and blood. So this area in the lower abdomen is an area where we do focus some of our assessment on, but primarily the space between the arcuate line and the costal margin. because this is actually where we get two layers, an anterior and a posterior layer of these rectus sheets as they come around rectus abdominis to attach onto the linea alba. And so this is where we have the best chance at balance of strength, and this is where we are really strong. And this is also a place where if something's going to go wrong, it's a problem. So this is our highest priority of force transfer and intra-abdominal pressure building. And so we look to this first in our assessment, and we prioritize this zone. And one of the reasons why we do that is because if we notice some sort of deficiency or fail-safe here, then it could easily leak into different parts of the abdomen and compromise our ability to build gut pressure and send it to the extremities and send it to the outside world. Now, what we notice in diastasis is it often occurs in this sort of area between the costal margin and the arcuate line. And like I said, this area is important because it gives you both an anterior and a posterior layer. The anterior layer is going to be made up of external abdominal oblique, the anterior portion of internal abdominal oblique, doing that sneaky thing. And then the posterior layer is going to be made up of the posterior part of the internal abdominal oblique and transversus abdominis. So we build gut pressure and then send it to the outside world. So Danny has a beautiful visual that shows this, and Kathy has, I mean, when is Dr. Kathy Dooley not an enormous wealth of knowledge and resources? But if you go to Dooley Noted, she does actually show this in you know, with respects to diastasis recti, and she's got a beautiful article about it. So if you just type in Dr. Kathy Dooley on Dooley Noted, you will find videos on diastasis recti and the rectus sheets. But for the purpose of our discussion, when we see that someone lacks lateral expansion in their torso, and it happens to fall in this area of priority for us, they start to lose extensibility and sort of get bound up on the side here. And when there's rapid expansion from posterior to anterior, like in the case of pregnancy or just even rapid weight gain, if everything moves forward to back and doesn't have any room to sort of spread out on the sides, you're pushing into the area that lacks extensibility. Remember, this is broad, flat tendon of connective tissue. Here's where you're have the extensibility to expand. But so many people have sort of lost that ability to find this lateral expansion. And this is one of the things that we focus on in our assessment. And so if you can imagine, if I had on a button-up shirt, let's say, and I had my buttons buttoned up here, and I started to pull on the sides, and then to the point where I needed to just sort of move anterior to posterior, maybe I was just trying to even breathe. And, you know, we do see that sometimes there are some faulty cueing within breathing when people are sort of told to breathe, belly breathe, front to back, right? That's going to be a little bit of a problem for the same reasons why rapid anterior to posterior movement is a problem. Yes, we do want to see a dome. We do want to see 270 degrees, but we want to see that sort of load share across the abdomen and not just front to back. Because if you push into something that already has a vulnerability, just like if I were buttoned up the front here without helping me move through the sides, I'm going to herniate, right? I'm going to herniate through my shirt. I'm going to herniate through my linea alba. I'm going to herniate through whatever I have zipping me up right here in the front. So that's how we start to look at this in immaculate dissection core concepts as well, is not only can we look at how to rectify this once it's happened, we still give them, you know, for the patients and clients that are experienced diastasis, what we can do to help that, and just to kind of bring it back to the question, is get them what they didn't have in the first place, which is good quality expansion through the lateral sides here of the abdomen. And so whether you're trying to prevent that from happening with some of your patients who are pregnant, or you're trying to help that for patients who just surgery is not an option, they're not interested in it, and it doesn't even need to come to that, because, you know, even with the case of like ventral wall hernias in general, with meshing and things like that, again, you're still at risk of this coming back if you don't find what you didn't have in the first place. So I'm going to default over to Danny now because I believe he's got some things he wants to show you here. But this core concepts is a really, really, really great way to learn how to better tackle this exact problem. So Danny, what can you give us a sneak peek for what you've got?
Let's see so I can actually see what's going on. So I'll be doing all this backwards.
Okay.
So kind of to visualize some of the anatomy that Anna was just talking about in regards to the aponeuroses and how they attach to the linea alba, and how, you know, the mechanics of breathing happen or not through the rectus sheets. This is a little visual that I have here, and it's basically going to be kind of like a little bit of a simulated dissection, showing the linea alba kind of here on the side, and then the aponeuroses of other muscles and how they interdigitate and work with rectus. So, as Anna was talking about, the main area that we kind of focus on is going to be between the costal margin and then the arcuate line right here. And there's going to be anterior sheets as well as posterior sheets during this area. So anterior sheets are going to be formed from IAO, which will be the outermost. Directly under that is going to be IAO with its anterior portion. And if you remember what Anna was saying, how IAO did that sneaky little thing where it splits and just kind of goes between rectus on an anterior and posterior aspect. I'll peel behind this anterior aspect of rectus sheets, of IAO, and check it out. It's rectus. So directly behind rectus, we're going to start coming into the posterior sheets. So we'll peel rectus out of the way. And then you can see the posterior portion of IAO, and then the rectus sheet that comes from TVA as well. And all of these guys are going to be attaching to, let's see, let's put you back together. Humpty Dumpty. Okay. But yeah, so they'll all kind of come together there, and they're all going to have this attachment to linea alba here. But as Anna was kind of talking about too, like in regards to breathing, in regards to what is it now, to lateral expansion, and how you're going to start seeing diastasis if you're only stretching anteriorly or only expanding anteriorly. And I was kind of thinking about it today when I'm like a little visual of paper napkins right here. And you can see when kind of pulling and expanding laterally, everything is okay. You know, everything's staying intact, so on and so forth. But as soon as you start pushing anteriorly and only moving forward, bam, it splits. So this is why, like in the seminars and when we talk and whatnot, you know, there's a lot of emphasis on that lateral expansion through breathing, because that's what's basically going to really fortify these muscles that create the rectus sheets and just keep everything together and stitched together and not split apart. So.
Danny, amazing. There you go, guys. I mean, never letting us down with the visual support. Thank you so much. And you know, I love that visual that you showed where your paper towel just got a diastasis recti. But I also love that you included rectus abdominis in your visual, because so many people start to think that this is a rectus problem, right? And they prescribe crunches and they prescribe all of this sort of sagittal plane movement to fix this problem. And it's just not where we're looking to. I got so excited about the topic that I completely forgot to share my screen with you for a second. And then I'm going to jump over to the teaching team and let them jump in there. Let me see what I can show you just to give you a sneak peek of some additional support here. View full screen. Can you guys all see this? There we go. Okay, perfect. So this is some more of Danny's beautiful work. And you can see where we have this zone here. Not that we don't care about above the costal margin or below the arcuate line. We absolutely do. And we take you through assessments accordingly. But we want to focus our work first on the area that's sort of the most important in terms of priority. And so we've got some cross sections here where you can actually see the anterior and posterior layer going around rectus to join up to the linea alba here. And Danny has color-coded these things very nicely. And all of this is part of what you get with the Immaculate Dissection courses, is beautiful visual support. And particularly for ID1, you get an actual rectus dissection brochure to take home with you. And people just, I mean, nerd out and love these because they're everything and more. So wanted to show you that. And now let's see. Monica, Kirby, Lisa, what do you guys have in terms of what can you tell us about your experience with diastasis? Lisa, go for it.
I'll jump in. I do see quite a few of these. I actually often see them on a lot of men who are who train a lot. That for some reason seems to be a huge population for diastasis, and you wouldn't think, oh, like young, fit, athletic men, dealing with this, but I see it a lot. People are always looking at pregnant women as, they're the only people who can have it, but we should really be checking everyone for this kind of stuff. And it's potentially like how they're training or whatever. But the big thing that I like to think about with diastasis that helps me kind of understand the mechanics of why it happens is all about the fiber direction of the muscles. So if you think about transversus, it has that really transverse, fiber direction. The fibers are running across like this. So when that muscle is tight, it pulls. And that's kind of how you can visualize how that comes apart and how that can really impact and create that separation. And as to Anna's point with, talking about how rectus, a lot of people think rectus is involved, the rectus fibers run this way. So it's pretty hard for that to pull that center apart. The fibers run the wrong way. So really focusing on those other muscles of, IAO or internal oblique and transversus, where the fiber direction is that transverse direction, is the key to this improving. I found a lot of success in working on the extensibility, so getting those muscles able to both contract and relax, and then really solidifying that with breathing. Often you see things just kind of, even within one session, you can see a change sometimes in the size of that separation.
Absolutely. And you were so right about the fiber direction, giving you clues as to where this muscle is going to sort of either help you out or get in your way in the terms of a pathology like diastasis. So that's such a great visual to have. Thank you so much for that. Kirby or Monica, yeah, go for it. Just unmute yourself and jump right in there.
Awesome. Anna and Danny, that was awesome. Danny, I really like your the paper towel display there. And to piggyback off of what Lisa was saying, I do see a lot of postnatal and prenatal population, but just to kind of agree with Lisa there, the people that I'm seeing it in, it's not just limited to that population. It's males, it's females that haven't been pregnant. It's just, what I would like to say, people who just haven't learned how to coordinate that musculature, which is a lot of people. So I think it's really important to learn that coordination. And after ID core, in my initial assessments, it's been a go-to of making sure, there is no diastasis or using it as a part of the assessment. But it also kind of brings to light the idea of, we're not just guessing which muscles to work on with diastasis recti. You're actually looking for those tight muscles and assessing why they're tight, and then addressing, what you can do with it. So that's been huge in the success rate of decreasing that diastasis and being more successful for rehab.
Absolutely. That's thank you so much, Dr. Chadha. That was really, really helpful. And it doesn't have to be a mystery, right? We actually lay this out for you in a flow chart, and we give you step-by-step instructions to follow. And so it really is kind of like, if you follow this sort of flow chart, then you're able to jump right to the area that is exactly the problem, and may have been the problem for a very long time. Certainly preceding the actual injury or pathology itself being diastasis. Dr. Kirby, is this something that you see in your practice? Is this something that you work with and have had a lot of success with? I can only imagine that you do.
Absolutely. And I was just going to piggyback off what everybody else is saying, and how we can understand it. To me, when I think about the lack of extensibility of especially TVA and IO, which is in direct response to diaphragm, we're talking about seeing it staying more shortened on the lateral aspects without that lateral extensibility. And I think about the attachment sites of TVA and IO to the anterior aspect of the thoracolumbar fascia, but also being the floor of the lumbar triangle attaching to the iliac crest, the ASIS, and then obviously down to pubic crest. So when I think about these things, I think that it has to have, we talk about load sharing in the spine, but I think it has to have load sharing even that 270 degrees, because that's what creates a stable pelvis. So if we're not being able to share that intral abdominal pressure all the way around the pelvis, that round structure, we're not going to create that stability at the pelvis. Then we're not actually going to be load sharing our intral abdominal pressure, and we're going to see that why these diastases happen, because it can't share in the lateral aspects.
Absolutely. I think that was just a gorgeous way of putting it. All of you guys, I'm so thankful to be part of a family with all of you brilliant minds. Yeah, I mean, it is. It does. We talk about this idea of load sharing, and we do prioritize, like I've said a couple times, this area where we get the anterior and the posterior layer of the rectus sheets. But if we're not sharing amongst the other areas in the abdomen, you may not necessarily see diastasis. You'll just see a different problem, right? If it's below the arcuate line and there's not a nice even load share, you might see, things like hernia and stuff like that. So it is something that we start here, because if there's a problem in this space where you are duly fortified in the front and the back, if there's a problem there, then once we go above or below that, then there's also an inevitable problem there. Because just like Kirby said, this is what's helping to stabilize your pelvis, and ultimately we need load share in that 270 degrees. So awesome, guys. Thank you so much. And, just to bring it back to the question that was initially posed, the way that you can avoid it without surgery really does sort of come down to just giving the person what they didn't necessarily have in the first place. And that's something that, ID has changed all of our practices, and it's something that we see all the time, and it really is a pretty foolproof technique. So we hope that you'll consider joining us if you haven't already. All right. So the next question that we have is, it's an ID3 question, actually, which is upper extremity. The question that was submitted is, my FMS shoulder mobility test is stuck at a 1, even though I stretch, foam roll, dry needle, do cupping. So far, pressing heavy kettlebells are fine and awesome. I watched your video on YouTube on kettlebell armbar for this issue. Can kettlebell arm bars help? Okay, so this is a great question. I'm definitely interested in what the team has to say about this, because I know that you guys are experts on this. We do actually use the arm bar. We use it with slightly different cues than some people maybe have previously seen. We tweak it a little bit just to prioritize and be consistent with our ID cues. We would never, ever sacrifice any of our ID cues just to go into an exercise for sport. So we really maintain a nice, strong, stable platform to do this. But what was so interesting is we don't start with the arm bar. We don't start with glenohumeral movement. We don't start, when we look at the shoulder mobility in FMS, we aren't starting with Applies and reverse Applies. We do still use it as part of our clearance for overhead. Just the person that asked the question mentioned pressing, but it's not where we start, because in ID3, we not only talk about the glenohumeral joint and how to clear somebody for overhead, we talk about the 6 functional shoulder joints. It's not just glenohumeral joint. In fact, if you don't sort of pass go on these other previous clearance markers, you don't even look at Applies and reverse Applies. And this is when we start to look at things like the scapulothoracic joint and the acromioclavicular joint and the sternoclavicular joint. And we need to make sure that our glenohumeral joint is set up for success to receive the force transfer and the stable platform as the shoulder girdle as a whole. not only that, it doesn't stop there, because we have to clear the core first. And we also have to look at external abdominal oblique's ability to take what the core has just built for you and send it up to the shoulder girdle. Because we spend so much time, we talk about EAO, external abdominal oblique, and ID core. Of course, it's part of your core. We really talk about it in ID3, and we talk about how that is the important upper extremity muscle that you never knew was your important upper extremity muscle, because of the things that it interdigitates with for scapular support, for force transfer. Because if you don't have that, none of this matters. None of this matters, none of this matters, none of these matter. So I want to hear what the team has to say about this. I know that Kris Kirby sees a lot of shoulder stuff with his pitching athletes. We've had Monica do a phenomenal quadruped position for us, and the amazing Lisa has done some pressing cues for us. So what do you guys have to say about this? Anybody jump in there? Just unmute yourself first. Monica, Kris, Lisa, Danny. Monica, go for it.
I'll jump in. So, you know, I feel like the answers to this are no different than any other answer to any other question we get. It really is, how are things coordinating and moving together? And where are they getting their cues? So if your cues are off, then everything's off. And, you know, you can move more, but you're not moving well. And so, for example, in the quadruped video, since you mentioned it, you know, the first things first is, you know, what is your core doing? What is your spine doing? And then how is that force being transferred out to the rest of the extremities? So when we're looking at an upper extremity issue, it's no different, like you said. You know, we're returning back to the core, because if we don't have that, then there's no point of even looking at this region. And to be honest, in practice, I've had absolutely no one yet that's come in with an upper extremity issue that wasn't a core issue first. And every single time I'm like, maybe this one, and no, not this one. So I think it's really, really important to see the full picture and not just move into loading or getting too excited with a movement, although I love it. You know, we really want to be there, but taking that path to really understanding where that movement's being created and how to best support the movement so you can load it and so you can do more.
Nice. Awesome. You're so right, Monica. And, you know, we do look at how, you know, all of our patients and clients, I mean, not to sound like a broken record, but that's one of the things that makes this sort of ID approach and this lens that we all use, makes it so foolproof. Like I said, I mean, it is because it ultimately doesn't matter what the condition is. It doesn't matter, you know, what the person is, you know, their history. Of course, we take all of that into consideration as part of their story and their narrative as to what walked them into our office. But ultimately, we follow the same rules with everybody. And, you know, Kathy has said before, I don't make the rules, I just follow them. And I think that that's brilliant and wonderful, because it starts to tone down some of the noise of, well, what about this person? And what about this person? And you know, it just really, really, really helps a lot. So Lisa, Danny, Kris, what do you guys have for me? Go for it.
Yeah, I know. I basically everything Monica said and you said is the same thing. We have to clear all the other things first. We can't skip steps. You know, it's great that you can do it pain-free now. It doesn't mean that it'll always be that way. You know, it might be that you're okay right now, but if you keep going with overhead work, that you run into a problem, and it's because you haven't cleared the other things first. So, you know, sometimes it is worth kind of going backwards a little bit, which isn't really going backwards, but it might feel that way, and kind of starting at the beginning and making sure that you actually have permission to go overhead. And if you aren't, you know, if you're at a 1 on the FMS, you don't have permission to go overhead. You don't have the mobility to do it. There's an issue there that has to be cleared first. So, you know, work your way backwards and make sure first, is that core good to go? You know, is everything there doing what it should? Is everything there coordinated the way that it should be? And then looking at, you know, the other things, like Anna said, the scapulothoracic joint, the acromioclavicular joint, the sternoclavicular joint, those things have to be working properly if you're going to go overhead first. And it's likely not an issue with the glenohumeral joint at all. So yeah, it's, you know, working your way back, clearing those things. And if you are going to press, you know, it's maybe thinking about, am I doing this in the best possible way? Am I able to do this in the best possible way? And if you're not, then it might be, you know, pulling yourself back to a point where maybe you're doing it in half kneeling or tall kneeling, just to give yourself a better opportunity to be able to press with good form.
Absolutely. And, you know, and I think that, you know, part of the question was asking about armbar. And I think that you know, armbar is a wonderful modification because it's not overhead, right? It does sort of change that glenohumeral angle. But I mean, everything that you said is so spot on, just in terms of, we have to look at the things that set the glenohumeral joint up for success, right? And, you know, the glenohumeral joint we look at joint centration. We look at the ability to joint centrate. We have dance moves for that I promise you will never, ever forget. But yeah, you know, it's just, I think that one of my favorite things that, like, even though we've done, I don't know how many seminars for the past 6 years now, one of the most fun things about it is to really sort of reinvent the lens that we take to approach exercises that are, you know, tried and true, and we love them, you know, whether it's pressing, whether it's an arm bar, whether it's a squat, whether it's a dying bug, right? We can sort of look at it from a different angle and kind of approach it slightly differently so that you get so much more out of it. But it may mean that it pushes those exercises a teeny bit further away from you. It's, you know, kind of like in ID2, when we have people that are squatting till the cows come home and don't have permission to squat, right? Because they don't have symmetrical lunges. So, you know, same thing with pressing. You know, the armbar, absolutely, we do use that, and we do gradually sort of help somebody reach a safe and stable platform to be able to do more overhead work with. But we also have this, like, very tedious sort of checkpoints of clearance to be able to safely progress you. Because just like Lisa said, if it's not painful yet, it doesn't mean it's not going to be. And thank God it's not painful, right? But we don't want it to get in your way and then sort of send you back to, you know, step one in the first place. So, Dr. Kirby, what do you have for us? Kris Kirby, jump in there if you can. If not, Danny, do you have anything to add? Either one of you guys?
Well, yeah, absolutely.
Okay.
Yeah. Go ahead, Danny.
Okay. Yeah, no, I was just basically going to reiterate and kind of go on the point of, like, again, it's arms kind of being, like, again, like, core is more so going to be centralized and focused in terms of biomechanics that we need to kind of work on first before it can move its way out to the upper extremity. And as Anna was kind of saying beforehand, how IAO, or internal abdominal oblique, is a bit of a liaison between core musculature and extrinsic musculature and whatnot. EAO is going to work very similar to that in terms of, like, power created in the core is going to be transferred up through EAO, up through serratus, which is again going to have a major role in the scapulothoracic joints and whatnot. And again, if these structures aren't built or aren't stable first, like, it's just going to be setting up a way for problems down the road. Like, you guys recall those Goldberg machines, or those Goldberg apparatus, where it's kind of like a moving part where marble drops, kind of moves forward, rolls down, knocks them down another piece, knocks down another piece. It's going to be really similar to that kind of stuff, like where all these moving parts need to be working in a proper order so that the end goal is achieved properly. So again, like, by having proper mechanics in the first place to kind of work off of, that's going to allow for the most stable platform to move forward safely. Because again, kind of as Lisa was saying, like, just because pain isn't there quite yet, like, if you're not moving on a proper platform, like, that pain will come eventually at some point in time. And, you know, that's something that obviously everybody wants to avoid. So.
Absolutely. That's such a cool visual. Danny, just bringing it on home with the visual references. We so appreciate that. Kirby, how you doing? What's up?
I'm doing good. Just trying to get better signal.
Go for it. We can hear you loud and
Everybody's
clear.
breaking up a little bit.
Oh, sorry.
Oh, okay. No, and what everybody's saying is absolutely true. So if we don't have that, we talked a little bit about mobility, stability, and strength, and how they're so intertwined that, what we'll absolutely see is that, and what everybody's saying, if we don't check core and how EAO transmits power up to the serratus anterior, and then checking your SCAC and ST joints for the triangle of stability for that mobile glenohumeral joint, whether it be now or whether it be later, you're going to end up with so many different types of injuries, but it's all really related to the same thing. If you're going to be trying to move off this the glenohumeral joint without being stable at the triangle of stability for the shoulder, it's going to flow down the chain, and we're going to get all types of tendinopathies, bursitis, and injuries that can happen. And I think that's probably why people feel like they need to stretch and foam roll all the time when they're trying to be mobile. It's because their body's trying to compensate for other things that's lacking in some other department.
That's so true. I absolutely, appreciate, and as someone who has a lot of manual tools available to me, I use a lot of needles, I use gua sha tools, all of those things that, we all have as part of our toolbox. But what is always interesting to note is, like, I've changed my relationship with so many of those tools, just because I've shifted where I'm sort of focusing my gaze to address a problem and a symptomatology. And that totally supports everything you're saying with that triangle of stability. Kirby, you had a really awesome video that was shared on the Immaculate Dissection page about the relationship of mechanoreceptors and nociceptors. Do you want to add anything about that, or can you share that, because it is a big topic with regards to the glenohumeral joint that we do talk about a lot in ID3.
Sure, absolutely. We talked about what centration means to all of us, and I know you and I and all of our teaching team has talked about that. To me, it's the basically interrelationship between two articular joint surfaces that have to maintain this proper positioning to sustain maximum loading. So what they found in research is that there's slightly thicker articular cartilage on both sides of the articular surfaces in one particular area, and there's more mechanoreceptors right at that area. And what that's telling us is that when that is being able to be properly maintained, we can get maximum loading in that joint. Outside of that, there's more nociceptive pain fibers. So there is a proper positioning that must occur in order to load these joints, and that goes into what you were just talking about, Anna. That if we don't have that stability of the shoulder, then the mobility is really, you're not going to be able to load that joint in order to move it, especially at the ball and socket glenohumeral joint, which is why the SCAC and ST joints is a prerequisite before glenohumeral, and then also core is a prerequisite to that, because we have to take it from the center up.
Totally. That's awesome. Everything that you guys said, it really, I feel like, drives this point home, and so appreciative for all of your expertise on this. Yeah, the FMS screen is fantastic, and like I said, sort of at the very beginning, we absolutely do use applies and reverse applies to sort of assess glenohumeral movement. Of course, it's a tried and true way to do that. We just have it within the context of other things, and we probably get to it a little bit later. It's not whereas I think on an FMS screen, like, that would be like one of the second things that you get to, right? This is going to be a little bit further. We sort of dissect the upper extremity a little bit further before we actually start to do applies and reverse applies. And you may be surprised as like one of Lisa or Monica had said that, they never really see a problem in the upper extremity that doesn't involve you know, some sort of core problem leaking into the scapulo-thoracic joint or the acromion-clavicular joint or the sternoclavicular joint. I know I was so excited this week. This is the weirdest, nerdiest story ever. But here we are in quarantine, and somehow I have managed to get tennis elbow. I don't play tennis. I don't know how I did that. I was probably doing some weird tricks in my living room. But I was able to use, I can't wait to make a video to this and just like blast it out to our attendees. I was able to use the ID screening and the ID protocol, walk my husband through it, who is a carpenter, by the way, like not a healthcare practitioner. And he, you know, with this sort of like step-by-step sort of hierarchical approach, was able to actually find where my problem was. Turned out I had a clavicular issue that was leaking into my ability to load bear. And I think that that's certainly relevant to, you know, I didn't have pain in my shoulder. I didn't even have pain in the joint that we found to be most problematic. I had pain right here. But as soon as we addressed it and we were able to like apply these correctives accordingly, completely dissipated. I didn't have to do anything. Oh man, you have no idea how much I wanted to initially be like, I gotta needle this, I gotta needle this, and I gotta needle this, and I'm gonna gua sha this, and I'm gonna cup it. I'm gonna probably light one of those cups on fire. But no, it's quarantine time. I don't have my tools with me, but I do have my ID skill set with me. And that was foolproof. You guys, it was so awesome. And I was so excited to like have a problem that I could look at with this sort of ID lens. And my husband was like, you're the weirdest person I've ever met, but this is pretty cool and kind of magical. So I'm down with it. He really appreciated it. And so did I, because now my elbow doesn't hurt anymore. So yeah, you know, upper extremity, like, again, like we probably so often sound like a broken record, but that's, Monica has like the most succinct quote that she said one time. You said that it seems complicated at first, but it's the only way to make this simple. I can't tell you how many times Kathy and I quote that. I mean, we you know, use that as words of encouragement to anybody that is approaching this lens and this sort of problem-solving strategy for the first time, because we get it. It is overwhelming. There's so many structures here. There's so much bursa here. There's so much opportunity to have something scream at you here. And, you know, but your assessment's the same. And in fact, we put it on a little bubble chart, flow chart, and we have all these wonderful visuals for you. So just to make your life a little easier. And then we're going to continue to talk about it on a weekly basis on these calls. So thank you guys so much for your insight into that. Our chat box looks kind of lonely, friends. Nobody wrote in it. And so if you have any questions, please feel free to throw something in there. We are almost out of time, but wanted to just see if there was anything left that you guys wanted addressed that we didn't cover tonight. And if so, we also have another webinar next weekend, same time, same place, same people. Lisa Burnfield, you're amazing. Thank you so much. And while we're just waiting, I will, before I throw an anatomy question up there for the attendees, I want to just tell you guys that we are so excited. This week marked our first inaugural episode for our ID Collaborative membership. What is that? That is a series of learning hours where we basically just have guest speakers and we talk about a topic and really sort of hit it pretty hard over the course of an hour. This past week, we talked about, you know, creating safe spaces in our clinical practices with patients with regards to gender affirmation and, you know, sort of gender diversity and how to address that and open up our clinical homes for everybody to be a part of. And we had the beautiful, wonderful Kate Wolofsky on there. And we had such a great time tackling this. And so we have all the way through May and June scheduled. We have an upcoming talk on Tuesday evening with Jonathan Fernandez. And Kathy, Dooley, and myself will also be on there, and hopefully a lot of your other team. I'm sure Danny will be on there, Monica, Lisa, Kirby. So we're taking these, a week at a time. We're doing 1 to 2 per week. They're $20 a piece, but if you want to just go ahead and say, hey, count me in for the whole year, you've got a year's worth for $200, which actually, when you look at 1 to 2 a week versus $20 a week, like this evens out to be like at most $4 an episode. And we are just really having a good time kind of researching and preparing for these. I know I certainly am. And we had a lot of fun. We want to share our family with you guys. We have such a wonderful team that we have worked hard to build, and information that we are excited to share. So if you are interested, please check this out. We are trying to give you absolutely as much as you can to participate from your own homes while we all sort of weather the storm together. So if there are no more questions, then I hope you guys have your fingertips ready, because I have a question for you. So attendees, get ready. The question for you is, who makes up the anterior and the posterior sheets between the arcuate line and the costal margin? So go ahead, find your chat box. Tell us who makes those up.
Is there any way I can ask a question, or would that not be appropriate at this time?
You're totally welcome to throw a question in the chat box.
I don't know where the chat box is.
The chat box, if you go down, if you just scroll down to the bottom of the screen here, you see a share screen, and then right beside that, it says chat. So here, let me throw something in there.
Okay, I just see Monica at the bottom. That's all I see.
Okay, did something just light up?
From Kathy to all, hi everyone.
That's it, that's the chat box.
Okay,
Yeah.
and it just disappeared. Do I hit the middle button?
If you just, if you click on that, someone else just joined in. Christine, you're partly right. Can you elaborate on that a little bit more? We're looking for who makes up the anterior sheath and who makes up the posterior sheath.
Is it, I want to interrupt.
It's all right. Just throw your answers right in that chat box. Christine, you're on a roll. Keep going with it. External oblique is part of the right answer. Talked a little bit about this and why we're interested in this area.
Is the chat box the third button? I'm just not, I don't see it opening up to anything.
If you go down, if you just move your mouse onto the bottom of the screen, you'll see a share screen, you'll see participants, you see mute, stop video, and there should be a chat. Looks like it's got a little dialog box.
I see it to do. No, that's not it. Kelly.
IO, EAO, and Rectus. Okay, so Mark, we're looking at the Rectus sheets, which actually go on either side of Rectus. So you're hanging in there with IAO and EAO. Maybe you want to tweak that answer just a little bit. Who makes up the sheets? IAO and EAO are correct. Not limited to that. Danny showed us this on his visual, not the paper towel one. That one didn't have any sheets, but it was amazing to see that completely herniate through that seam.
Should be Rectus Sheets on that one.
Yeah, it was just a Rectus sheet. Love that. All right.
Chat. Oh boy, I don't know where the chat is. I don't know how to do this. This is weird. Free phone call, that's not it.
On the toolbar of your Zoom screen. IAO, EAO, Rectus, linea alba. So we are connecting to the linea alba. We've got IAO and EAO. You are correct about that. Rectus does not make up part of your rectus sheets. The rectus sheets are made up of something else from other structures. We're missing one pretty important one. Who makes up the rectus sheets? Anybody got an IAO? IAO is definitely in there. He's doing something pretty cool and sneaky, splitting into 2 separate pieces. EAO is definitely in there. We need a little help from more intrinsic support, though, for these rectus sheets to attach onto the linea alba. One more. Oh, Christine. Hey-o. We got an IAO, an EAO, and a TVA. Christine, do you remember, haha, do you remember which one of those splits to make up a little bit of the anterior and a little bit of the posterior? Which one was the sneaky one? IAO, yes, ma'am. Okay, so Christine, here's what I'm gonna have you do. You got a $50 coupon for some of our immaculate dissection coursework. If you can email me at immaculateDissection@gmail.com, I'll hook you up with that coupon. And all right, cool. Thanks so much, everybody. Massive thank you to the ID team. I love you guys so much, and we are all sending our love to Dr. Kathy Dooley. You're just, I mean, we're all here because of her. It is just her wonderful wealth of knowledge and passion that has made all of this possible, and we love her so much. So that is all for tonight, and we hope that you guys will join us. If you have a question that wasn't answered, if you want, we can certainly answer that next week. You can put it in on social media. You can send us an email. You can put it in the chat box. And we will look forward to seeing you next week. So thank you all so much. Take care. Have a great week.